Hi, I'm Ken Goldschneider. I'm one of the pain physicians and members of the EB team at Cincinnati Children's Hospital in Cincinnati, Ohio, in the United States. Today, I'm going to talk about treating pain and itch in EB. Now, the 2012 practice guidelines, of which I was the lead author, were funded in part by a grant from Deborah USA, and we will be using a lot of the recommendations from those guidelines in today's talk. And we will be talking about off-label use of medications because that's very frequent in the pediatric population. Now let's start in infancy. There are a couple of things we can do that are possible and helpful in infants that are different from the usual use of acetaminophen, opioids, NSAIDs, and that kind of thing that we use in older people. Sugar pacifiers are a really good example of that. A sucrose solution or simple sugar solution can be analgesic in babies up to age 6 months. When it's possible to combine it with sucking on a pacifier, that's even more effective. So this is something that can be used for relatively simple and painful procedures and things that come up back in the time when the kids are still in the nursery, basically. But it is simple, it is safe, and without much in the way of side effects. Now, starting in infancy, of course, bathing and dressing changes are a recurrent source of pain. And per the guidelines, we recommend that these therapies should focus both on pain and anxiety using environmental, psychological, as well as pharmacologic approaches. Now, one of the first things that we talk about with new parents or new parents to the EB world is that dressing changes and baths do not have to happen every day. And by doing them every other day, you can decrease the amount of pain that the child is experiencing, but there's not a lot of downside dermatologically. Obviously, there are times where a bath or a dressing change needs to happen every day, but as a general rule, we start out by recommending cutting the pain in half by not doing it every day. We use systemic analgesics and anxiolytics. We recommend distraction for all ages, and distractions can be anything from mobiles to watching videos or whatever else you may have. Really, what you do is only limited by imagination. For older kids and young adults, cognitive behavioral therapies can be very useful, and we'll get into some of the more high-tech ways of distracting and using those kind of interventions a little bit later in the talk. Now, in addition to doing the dressing changes and baths every other day, we recommend that they be done in a calm, warm environment and to watch for breezes through the ventilation system and that kind of thing. Because if you have an open wound and then have something blowing on it, that's going to cause pain. So you don't want that. The next bit is preparing baths made with saline or to approximate saline. It's created with pool salt because pool salt is generally relatively easily available in large quantities and is relatively inexpensive. And this study took a look at the effect of saline baths and found that it reduced the pain of bathing in the vast majority of patients who participated in the study. And when combined with some of the systemic analgesics that were used, the effect was greater when the two were done together as opposed to just the pain medications and regular bath water. Saltwater baths can be made according to a recipe that is found on the Deborah International website. Now, anxiety builds up anytime someone can expect to have something unpleasant happen to them. So baths and dressing changes are a big source of anxiety because they hurt. So for treating the pain acutely, we use a variety of medications, which we call benzodiazepines and sometimes atypical antipsychotics. Those are good for in-the-moment pain, and in the moment means, for a few hours. They're not long-term medications. That is to say, if you have someone with anxiety all day, every day, these are not appropriate medications for that. They end up causing more problems than they do benefit. So for those, we recommend psychological interventions as well as some of the SSRI type antidepressants, which can be helpful for that. Now, gastrointestinal pain. This is where I start talking about nutrition. In the next several slides, you'll hear the word nutrition a bunch. And that's because not only is gastrointestinal pain unpleasant just because it hurts, it often interferes with normal bowel function. It interferes with eating, and eating is the basis for our nutrition. And if we don't have good nutrition, then we have skin breakdown and bone breakdown, and then pain comes from that. So treating gastrointestinal pain is a big deal. Constipation is an issue when there's perianal lesions, and constipation will cause perianal lesions because it will tear the skin around the anus if you pass a large, hard bowel movement. So attention to proper pooping schedules and keeping the stool soft is important. Also, strictures and reflux are a source of pain. And I just want to, I think the next slide, this slide here will be of interest because it kind of shows what's going on in the esophagus when we talk about esophageal strictures, because I think all of us have a pretty good handle on what constipation is all about. Let's start with the slide, the photo that says after. What you're seeing is a picture of a fully dilated balloon in basically a normal esophagus. So when necessary, the esophagus can open pretty wide and let food go down. And that's what's supposed to happen. But if you look at the before and then the small slide just on top of that, you can see that it can get narrowed so that you can have it nice and wide, and then it gets narrow, and then it widens out again. Well, food can get stuck at that narrow bit. And in fact, looking at that small top picture, you can see that it gets so narrow that it's all filled up of dye above the stricture that almost nothing goes below it. And that's why it becomes so hard to eat and why it hurts so much to eat when there's a big stricture. And if you reverse the order now, you start out with a very tight stricture, and then you start to widen it out and then pop it open. And now the person can go back to eating a little bit more normally. But so I just want to share with you just for the extra 30 seconds worth of time, what the process is of opening up that stricture and what the big deal is and why it interferes with eating. Now, bone and joint pain, we want to use that N word, the nutrition word, because folks with EB often can't be as active as other folks. And it is the activity that helps our joints and our bones stay strong. So we want to make sure that if that's not happening as much as for somebody else, that we have enough vitamin D and calcium in the diet to make sure the bones are as strong as possible. Joints, of course, scarring in certain types of EB can become a major problem and deform the joints and make it difficult to walk or use the hands or to sit with good posture and those sorts of things. And it is really important to be involved with occupational and physical therapy, as well as a number of mechanical interventions like orthotics and that kind of thing for pain relief, because there's only so much that a medication can do. We do use medications, of course, but when you have deformities of the joints, you have mechanically based pain, and there are really no good chemical fixes for mechanical pain. Now, for skin and wound pain, prevention and rapid healing are extremely important. And we use the non-adherent dressings, we pace our activities, we try to have the best nutrition possible for wound healing, and try to control infections. These are all priorities in pain management as they are for general EB care. Now, one thing that you may find interesting and is not as widely known is that there's evidence for what we call a sensory neuropathy, at least in RDEB. And what happens is that the number of nerve endings that are normally found in the skin, right around the junction of the skin, and you can kind of see these little yellow arrows pointing to them in that top photograph, those are diminished. So the repeated wounds seem to kill off a bunch of the nerve endings. But what happens is that the nerve endings that are left become hypersensitive. So they become not only easier to stimulate, but they amplify their pain more rapidly. And so we end up using some of the nerve pain medications, and it may explain why those medicines seem to help a little bit more than we otherwise would think. And I'll talk about those in a minute. Now, eye pain can come from corneal abrasions, and we do our best to prevent those with all the lubricants and eye protection and so on. One of the new things that's been looked at is extended wear bandage contacts may be able to be used to reduce the pain and promote the healing of corneal damage, which would be a very useful thing in EB. And we've had a few patients now try this and find it helpful. Now, as far as classic pain medications, people think about opioids. And when you think about opioids, there are many, many types of them, and there are a whole range of ways that we can give them to the person. And this could easily be a 2-hour talk. But the bottom line, in a practical sense, is what do you do to choose when choosing the opioid, and the way of giving it is like walking into a Swiss candy shop and trying to choose a good chocolate. Well, the bottom line is, here's what I teach my trainees, the folks that I'm training. I train them to ask what has worked before, because by age 10, most folks with severe skin disease have some experience with these medications. There's no need to reinvent the wheel, and they should ask what's worked before and what's the experience been as far as side effects and benefit. Now, the flip side is, for families and for the patients, you should feel free to speak up and say, hey, this is what I've tried before, and this is what's worked, and this is what, if there's been problems and so on. So the other thing to know is, what's the context? Is the pain relief that's needed long-term, or is it just for short bursts of time, say a few hours at a go? And we can adjust the medication choices based on that. We do tend to avoid codeine. Now, if a person comes in and says they've used codeine, it works well for them, that's fine. But you will find that many of us don't offer it anymore. And that's because we have enough evidence to say that there's a lot of genetic variation from one person to another that makes codeine either not work at all, or overwork, or cause significant side effects because of the way the body handles it. So if somebody happens to walk in and say, hey, that really works well for me, I'm not going to argue with them, and I'm happy to prescribe it. But that's why you're going to find a lot of doctors and nurses will not recommend codeine to start with. There are better choices if one's getting started for the first time. And then, of course, we have to choose whether it is possible to take pills or whether liquid is required, or, for instance, those times where it has to go through an intravenous line. That all determines a number of factors. I'm sorry, that's a big factor in determining which of a number of medications to use under those different circumstances. Now, biopsy pain comes up every once in a while when we have a lesion that looks kind of suspicious, and we want to take a piece of it to determine whether it's something to worry about or not. And this slide basically just lists that there are a number of ways that we can combine to make the injection of local anesthetic more comfortable, and then the local anesthetic makes the biopsy more comfortable. Pain after surgery, this is actually breathtakingly easy. We use opioids, we use ketorolac, acetaminophen, ketamine, nerve blocks, epidurals. In other words, we can do pretty much the same thing we do for everybody. The only limitation is experience or exposure to medications where a person might be tolerant or have known side effects, and we can take that into account, but that's true for others as well. And if we're going to do an epidural or a nerve block or a nerve block catheter or something, as you can see in this picture for the young man who had wrist surgery, we need the area where we're going to put the needle to not have a wound. So if there's a wound, then we have to think about other things. But other than that, just because someone has EB does not mean we have to do anything hugely different compared to everybody else. We should be able to offer the same things to everybody. And I mention that so that if you're ever in a discussion about what could be done after a surgery, it should be based on what the surgery is, what the expectations afterwards for recovery are, and if it involves any sort of nerve block or nerve block catheter, whether the skin in the appropriate area is clear or not. But that's all. Now, virtual reality is kind of a new thing. It's been around for a while, but it's being used more and more after surgery and for procedures and that kind of thing. And you can see this young person in the picture undergoing therapy after a burn. This is something that, as the headgear is made lighter and easier to use and the technology advances, could become much more useful for folks with EB. So I'm putting it out there so it'll be on all of your radars to kind of keep an eye out for it. Now, switching over to chronic pain, which is very frequent, and chronic just means long-term, like chronograph. It's all from chronos, the old ancient Greek word for time. So it has nothing to do with severity, for what that's worth. We treat it with what we call multimodal or multidisciplinary treatments. And the reason for that is that pain is an experience, and over time, it builds up to be a bigger experience than just the sensation of pain. So we want to make sure that we are addressing medication needs. We want to make sure that we have mechanical treatments, such as I talked about for joint pain and bony pain, and psychological treatments as well, because we are complex creatures. We are not just hurting body parts. There's a lot to us, and we want to make sure that we address all aspects of our pain experience to get the best results and the most relief, the least suffering, and the maximal functioning. Now, a few non-traditional pain medicines that pop up in use in EB, as well as in other folks with chronic pain, include the tricyclic antidepressants and the anticonvulsants. These have decent evidence for use for nerve pain of a variety of types. They sometimes can help itch, and we'll talk about that in the section on itch at the end of towards the end of the presentation. What they do is they stabilize the nerves when they have become overly irritable, and therefore do not transmit the pain messages quite as fast. And there's been some evidence that, for instance, gabapentin has been useful in burn pain and in burn-related itch, as I'll tell you about shortly. Cannabinoids, this is a big topic, medical marijuana and everything related to it. This is what's out there as far as evidence in EB. It's not much. Two reports of 3 patients each. And that's kind of the summary of where things are with medical marijuana. It has become legal in many, many places. In the United States, it's been very patchwork. So if you ask a doctor in one state and then you cross the state line to another and you ask a different doctor, you may get 2 different answers as to what's available, what's possible, and what's recommended. The other problem, besides the variable legality of it, is that no evidence means there's no evidence. That is to say, we cannot say to use it or to not use it, if it's a good idea, a bad idea, what the strength is, what route there should be, how much, how often. We don't know any of that. This is all anecdotal. The issue comes down to the legalization of marijuana was a social movement, not a medical movement. And therefore, it's out there and people are using it and asking about it all the time, well in advance of the medical evidence. And so we're still playing catch up. So that's a long-winded way of saying that it's out there, it's a reasonable thing to ask about, and you may not get good answers when you ask. Now, herbs are another form, of course, plant life, a little different from marijuana, but used frequently and has been used for a very long time for medical purposes of a variety of types. I can't really comment much. There's not a lot of evidence one way or another. There's nothing in EB that I've seen, but the one thing I do recommend is that you treat them with respect, because they can have some significant side effects. They can have some significant interactions with known medications. So they can be useful, and I just advise people to use them cautiously as you would with any medication. Now, topical analgesics, lidocaine is one thing that we use. It's a local anesthetic and needs to be used very carefully. We don't know how much is absorbed if it's put on a wound. So we tend to use it for very small wounds for very short periods of time. Large wounds or absorption of a lot of it into the system could cause seizures or other problems, so it needs to be done carefully. Morphine is useful for some folks. Some folks, of course, don't think it does anything. And we do find that how it's made up makes a big difference. So the way we make it tends to be tolerated really, really well, whether it works or not. I have also run into a good number of folks who have had it made up in different ways and found that it was not tolerable, so they never really knew whether it worked or not. So this is something where it's a bit of trial and error. The way we make it, I've put the ingredients here, does tend to at least go on wounds well without hurting, but there may be other ways of doing it out there, and that's something that you have to work out with your local medical team. Cognitive behavioral therapy, I've mentioned a couple of times. We have thoughts, we have emotions, and they play a huge role in how we tolerate pain and how we function in the face of pain. So a skilled pain psychologist is invaluable, and we have one as part of our clinic, and we have always had from day one. We will not see patients if they refuse to see a psychologist, not because we think they're crazy, because that's how much we value what this part of our team has to offer. And the problem is not everywhere has good pain psychologists, but many general psychologists and psychologists that work with folks with chronic illness have many of these skills. And I highly recommend that when kids get old enough to be able to interact with a psychologist and understand some of these concepts, that starts to become part of the pain plan, because there is no downside to any of it. It is without side effects, without interactions, and many folks find it helpful. And it's not that it magically makes the pain go away, but if we can help coping and improve functioning, then we've improved quality of life and decreased suffering. And that is totally worthwhile. Now, adjunct therapies, people have asked about acupuncture. There's some evidence that acupuncture by itself helps. There was a pediatric study a good long while ago where they combined it with hypnosis in pediatric patients and found that it was helpful. People used yoga, meditation. Again, all things that can be helpful, which really don't have much in the way of side effects. There are no drug interactions to worry about. They are all safe, and they should all be considered. Now let's switch gears a little bit and talk about itching for the next few minutes. It's a terrible problem for a lot of folks with EB. But there are some new treatments available, and I'm going to build up to that. So starting with topical approaches to itch, emollients, meaning kind of moisturizing, lubricating creams, lotions, ointments, and so on are often used. Topical steroids can be useful, but need to be administered carefully and with supervision of your medical team, because absorption of steroids can have effects throughout the body. Things like different garments, wraps, that kind of thing are also useful and should be discussed with your dermatology team. Psychological approaches to itch, well, that's important for pain, it's important for itch. One of the things that we find is that when the kids get stressed or they're anxious, they tend to scratch more. It's a habit, it's a way of releasing some of that tension. Problem is it tears up the skin. So the psychologist can sometimes be helpful in reducing at least that part of the itch experience and decreasing the damage to the skin. Now for medications, these are used frequently, and we're going to run through a number of the major classes and some of the pros and cons for each of them. Antihistamines are your classic anti-itch medications. These are great when histamine is the reason for the itch, but it's not clear that that's actually the problem with EB-related itch. So therefore, a lot of people use them. Some people find them useful. A lot of people don't find them useful. And others, I think, get some benefit because they can have anti-anxiety effects and can make people sleepy. So taking them at bedtime helps people relax and sleep. And that's not a bad thing just by itself. Ondansetron is something we used for a while. You may see some reference to this. We don't use it so much anymore. It does work for some types of itch. Our experience in EB was about 50-50. So I have no objection if someone wants to try it. You have to make sure that it doesn't interact with other medicines that are being taken, but it's generally fairly well tolerated. And if it works, great. And if it doesn't, not a lot of harm done. Gabapentin, I started to mention earlier, it's an anticonvulsant. It's used for nerve-related pain and generalized pain, but it also, for similar reasons, helps with itch. So because pain and that kind of burning pain and itching often go together in many of our patients, this is a medicine we use quite frequently. Fortunately, it comes as a liquid and it really doesn't have any interactions with other medications. So it's great that way. We do watch carefully for mood effects because kids, especially adolescents, can become suicidal on this. It's not very common. It is overall a very safe medication, but like anything, should be taken and treated with respect. Doxepin and amitriptyline can be useful. They tend to make people sleepy, so we tend to use it at night. It has a lot of drug-drug interactions and has some toxicities that are significant and need to be monitored. So we use this a little bit less often than we use the gabapentin, but these do have a role. They can be useful and are used frequently in EB. The newest group of medications, and where there's emerging evidence, and this is really exciting, is aprepitant and serlopitant, are what we call neurokinin 1 inhibitors or NK1 inhibitors. They were originally designed for anti-vomiting purposes, but there's growing evidence for use in itch. Our colleagues out at Stanford University have released a pilot study, phase 2 study, as it's called, and are doing a bigger study looking at serlopitants and are starting to find it useful. Now, I've not seen the final results, so I can't tell you anything more than what their original pilot study suggested. I can tell you that we've been using aprepitant for about 18 months in our institution, and when it works, it's spectacular. When it doesn't work, it just doesn't work. It doesn't have a lot of side effects, does not interact with very many medications. It is expensive, so when that's an issue, depending on insurance situations, healthcare coverage, that kind of thing, can be a limitation. I think there's going to be a lot of potential for this in the future. We are putting together our evidence, and hopefully we'll publish that in the next year or so. And so combined with the evidence that's being developed by Stanford and hopefully others, we hope to be able to share with you some good progress in the treatment of itch. So that concludes the talk. I appreciate your time and attention. I can be reached through the EB Center at Cincinnati Children's Hospital or through Deborah International. They can usually get hold of me as well. Whatever email or contact you have would be fine. And remember, there's a whole team across the entire planet who are behind you, and they all have different contributions, and I give them credit for the amazing work that they do. But so many of the things that they do for their specialties end up making pain better, and that's why I specifically include them here. So thank you once again. I appreciate your time, your attention, and wish you all the best.